Hi everyone, welcome to today's OEH seminar. Today we have with us Sharon, Provost, and Michelle Naimi. After a 32-year career in healthcare, Sharon left the leadership position to pursue a PhD investigating emotional health issues in the healthcare workplace. Her goal is to conduct meaningful research that models partnerships between academia and the public sector and provide practical information and tools to support leaders in creating healthy workplaces. For her PhD research, Sharon is using a realist approach to conduct a review and evaluation of the provincial violence prevention education in emergency departments across British Columbia. Michelle is a researcher with the Partnership for Work, Health and Safety, School of Population and Public Health at the University of British Columbia. She has also worked as an external evaluator on health-related programs across BC, as well as a senior researcher with Indigenous and Northern Affairs Canada. Michelle holds a Master of Evaluation from the University of Melbourne and a Bachelor of Arts from Simon Fraser University.
Thank you. Well, thank you, everyone. I'll just figure out how to make sure the microphone picks up. So we really appreciate people's interest today. So what we're talking about is going to be a review section of the realist approach to the violence prevention education. And so for people who are not as familiar, although you might have seen some of these headlines, violence against healthcare workers is a really major issue. And it's an increasing issue, and it's a really international problem. And as evidenced in some of the pictures here, is healthcare workers experience a lot of verbal and physical abuse from those they care for. So when we're talking about violence, we're not talking about from peers or from strangers who are conducting terrorists. We're talking about people they're serving, whether it's patients, residents, clients, visitors. And it's more dangerous to be a healthcare worker than it is a police officer or a prison guard. So they're experiencing more violence than others do, which is not as widely known. One of the issues we have is that violence is chronically underreported in healthcare. So even though there's been 4,000 reports in this 5-year time period, we actually know that's at very best about 30% of the violence that actually occurred. So there's been a real normalization of the violence where people believe it's just part of the job and they put up with it. They don't report it for a whole variety of reasons. And there has been a lot of research. In fact, the vast majority of research has been quantitative research about the prevalence, incidence of violence, and some of the factors that contribute to violence. And we're taking a slightly different approach, and particularly given that we know that the information there about the amount of violence and the reported violence is not accurate. When we want to evaluate how programs are affecting it, it's really hard to know whether there's been a change, because if there's a change in reporting of violence, you don't actually know what that means. You don't know if people are suddenly reporting when they didn't previously, or whether or not you've actually changed the situation where there's less violence. So the main intervention that has been used in healthcare facilities pretty well internationally has been to educate the healthcare worker. And the education is sort of gold standard, has followed these buckets of information. We're really looking at talking about violence, getting people to assess the risk, how to manage their own emotions, managing it when it happens, preventing it, and reporting it. What has been difficult, though, is to actually figure out if it's making a difference. So when we went into the literature and we said, okay, what has happened? There has been some reviews done on the violence prevention education. So if individuals have done violence prevention evaluations of their own program and then the reviews, pretty well across the board, it's been the fact that they really can't tell. It's unconvincing. And when you think about a program that no program in the world is going to work for everybody in all situations. And so when you average it and you say, did it work? Really what you're often coming out with is a net zero. It worked here, it didn't work there, it kind of looks like it didn't work. And particularly related to the low amount of reporting, if reporting goes up, some of the studies actually indicated that it got worse. So they made it look like education made the problem worse, when really we realize in the background that there's something else going on. So we decided that we were going to take a different approach to looking at the literature and then eventually the actual problem of out in the field. And what we're using is a realist approach. And it's something that sits between the positivism and constructivism that says, yes, we realize that there is some truth out there in terms of things that we can agree on. And yet there's also, we see the world through our own eyes. So we have a combination of those things at any given time happening for us, where there's enough commonality, but there's some individuality. And it's a matter of exploring those things. It helps us find the opportunity to understand the problem and find some solutions. So within a realist approach, if we looked at a basic education program, and so the basic theory, if you think about, you give someone a course, and this is in particular for something like in-service or continuing education. If I give knowledge and skills, what I'm really hoping for is change caregiver behavior. The knowledge and skills isn't actually changing the person doing the violence, it's changing the person receiving the violence. And we're hoping then that what that will happen is there'll be decreased violent incidents and related injuries and increased reporting. But there's a bit of an unknown in this big black box as to how that happens and why it happens and why it doesn't happen. So we have an opportunity to explore that. And from a realist theory, we say, okay, we give education and something's going to happen. The capacities and decisions about applying training are how are people able to learn and how are people choosing to apply it or able to apply it. And that's particularly when you take something like a healthcare setting, you give a course, and it's been a huge rollout of the education across British Columbia for those who are involved in the healthcare sector, where it's been mandated that people take the education. And so we need to figure out what's helping them learn and what's helping them apply it. And from a realist perspective, the circumstances and context that people work in and take the course in can influence how they perceive the course, how they perceive the information, and are able to use it. And so it's really what's happening in an individual's head, their reasoning, their beliefs, and their own personal resources, and that's going to change depending on the context that they're in. And what that does in the end is lead to whether they apply the education, knowledge, and skills or not. And so it's a bit of jargon, but in the realist literature, what you'll see is context and mechanisms equal outcomes. And these mechanisms are going to change depending on the circumstances. And some of those circumstances can also depend on who you're talking about. So to take a really, really basic example, and I seem to have been talking about reporting, so we'll continue on the theme. If the education is encouraging people to recognize and report violence as being important, but when somebody does report violence, the circumstances and context that they now work in, they never see any action when they've reported before, whether they or their colleagues. So I put in this report and nothing happens, big black void. The reasoning can lead to there's no point in reporting, a cynicism that says, what is the point? And in turn, not surprisingly, that person is unlikely to report. So when we start to figure out not just they're not reporting, but why aren't they reporting? And what's the underlying reasoning and belief attitude that's influencing that? And what is the circumstance that's influencing that reasoning and belief? We start to see where the opportunities lie. I'm going to hand over to Michelle, and I'm going to walk that way so we don't do a mic crossover thing.
Okay. So as Sharon was talking about, our first step in this project was to do a realist review. And it differs a little bit from a more traditional literature review. So I just wanted to talk a little bit about the key features involved in a realist review. And the focus is really on finding articles that are going to inform the why and the how. So as Sharon talked about, we're looking at in what kind of context are specific mechanisms triggered or fired and lead to which outcomes. And so we really want to get at those explanations as to why things are occurring and how. And it looks at a wide variety of sources for information, and the search is really an iterative and ongoing process. And so we'll come across an explanation at a very high level and then maybe dig deeper and try to really get at what's going on, and then it'll go back up to another explanation, and it's just sort of this ebb and flow process that is ongoing. As we come across one study, maybe that leads us to another idea, and so we'll go down there and explore that and then come back. In terms of depth, so we're looking for reasonable generalizability. And again, we're really looking at those explanations, the how and the why, as to why we're getting certain outcomes in certain situations. And at the end, we're looking for a synthesis and really a pattern of effectiveness. So as Sharon talked about, everybody has different interpretations of a phenomenon or something that happens, and we're really looking at those patterns of behavior to help inform our understanding of what's going on. And so in our realist review search strategy, we initially started out with a bit more of a traditional search strategy, just because we wanted to ensure that we were capturing all the information in a broad sense from the beginning. And so we specifically looked at the healthcare, psychology, and education disciplines, because those ones were really identified as being the most relevant to this study question. And we looked at 6 different databases. Document types were primarily looking at reviews, primary study, as well as some gray literature. And the key search terms that we were using was particularly around type 2 violence. So as Sharon mentioned, it's really around that the violence that occurs between a service provider and a client or patient. So in this situation, it would be somebody providing health care to a patient. We also looked at search terms around violence prevention, intervention, as well as intervention evaluation. And to start off, we had over 1,600 references. As I mentioned, we started off really broad, and after consulting with some realist review experts, we really narrowed down our search and screening for relevance and credibility. And when you're doing a realist review strategy, relevance is really around whether or not the articles are helping to provide explanations to inform that how and why. And the credibility piece is around the methods that were used in the study, and are they seen as credible. And at the end, we came up with 51 articles that we included in our review. So I want to talk a little bit about our data management and synthesis process here. So we did use in vivo, and each article was coded as, was used as an individual source. And for our coding process, we did partial or complete explanations. So if a segment of a text really was succinctly able to put together the context, mechanism, and outcome, then we would code that as one full CMO configuration. That didn't certainly always occur, in which cases we would code for specific context, mechanisms, and outcomes. And so each explanation had one theory code, and those codes were being continuously refined and grouped iteratively through the similarity of the explanation, the area, as well as the outcome. And through this process of continuously refining and grouping our explanations, we were making memos of our decisions and discussions. We also engaged in a process of conceptual mapping of ideas, and that was really kind of a sense-making process for us in our refinement process for these explanations. And we also did a review and comparison of the refined explanations and the data. And along this whole process, we had the guidance of Dr. Chris McLeod and Dr. Maura McPhee, who were helping us oversee the process, as well as the findings and talking about the explanations that we were coming up with through this process. And we also, as is part of a key realist process, we're looking for supportive formal theories. One example would be Bandora's theory around social learning. And so looking for those already tested formal theories, and were they able to support our findings and our explanations or not in some instances. And so once we had this sort of part of the process complete, then we started using Excel, where we transferred our refined explanatory theories and took specific examples from the texts, as well as supporting formal theories, and really tested out to see whether or not those explanatory theories we came up with really held water. And so Sharon and I did that individually, and then came together, and really it was a constant questioning of, does this really hold up? Does this make sense? And in order to result in our final set of findings and our conceptual models and recommendations. And so those are what I'm going to talk more about in the next few slides. So in coming up with our initial key findings from the review, we found it really useful to position it along a continuum and almost like a timeline. So here a staff member is given their violence prevention education, and then they'll invariably go back to their clinical work on the unit. And at some point, they will likely face an episode of aggression or violence from a patient. And then there's sort of that post-aggression violence period. And so there's a number of factors and components that can be placed along this timeline that we grouped as our key findings. And there was around learning, the team, individual capacity, support, and debrief. And along the entire continuum was work culture. So I'm going to break these down a little bit and talk about them in more detail. So around the key finding, the first one around learning, and you can see it sort of positioned both around the violence education as well as back when you're working in the unit. So if there is unit level role modeling of violence prevention skills, of mentoring, as well as access to expert advice, then there's an increase in learning and integration of skills into one's clinical practice. So again, I mentioned that was being supported by Bandura's social learning theory, so that really that sense of role modeling and observational learning all play a factor into one's ability to really learn those skills and start to apply them. And so there, as the outcome, we have resulting in an increased use of violence prevention approaches. And that would include things such as communication style, the ability to apply de-escalation techniques. And our second CMO configuration for learning was around whether or not the education, if the education is specific to clinical settings, it's delivered by credible trainers, and uses relevant example scenarios, then there's an increase in valuing of training that enables reflection and applying to practice. So if the trainer has had experience working in, for example, an emergency department unit, they really understand what it's like on a day-to-day basis working there. The examples they give are really examples they've lived, and most likely examples people in the course encounter that really sort of solidifies what they're learning, and they're more able to value the training. And that will lead to an increased use of behavioral care plans in both preventing and managing patient violence. So the second key finding category is around individual capacity. And you can see here it's positioned around when the staff member is back doing the clinical work on the unit. And so when a staff member's workload has a workload that enables them to meet their patient needs, that means they have the time and the capacity to observe patients and access their knowledge and skills. And that results in an increased point of care risk assessment for violence. So if a caregiver really has the time and then they're able to assess and maybe pick up on subtle cues of when a patient is starting to escalate, and then they're able to do those point of care risk assessments and hope in the end goal of really hoping to prevent violence and de-escalate it before it starts. And so as a second point, when a staff member has sufficient personal, physical, and emotional energy, they're better able to self-regulate their own emotions when they're interacting with a patient. And that, again, leads to an increased use of those violence prevention approaches, such as communication and de-escalation. And when a staff member has previous secondary psychological injury from a violent incident, and that concept around secondary psychological injury is from the literature around trauma and violence, which really talks about sometimes if a person has been a victim of violence, it's not just the violent incident themselves that can be damaging, it can also be the follow-up. So if that violent incident isn't acknowledged and they aren't receiving support, it can actually be even more damaging than the initial violent incident. And so if a caregiver has that secondary psychological injury, there can be an increased fear of being perceived as incompetent if they were to perhaps take a risk and try new skills if they're not certain it's going to go well. And that could lead to a decrease in the use of violence prevention approaches. And the next area is around support. And so this is really positioned around when a violent incident is happening, as well as that post-aggression or violence period. So if there is physical support from supervisors and peers during a violent incident, so if people actually come and stand with them and are by their side during an incident, then there is a decreased fear for personal safety, as well as an increase in confidence in managing violence, because that person knows that their peers and supervisors have their back, quite literally. And that can result in an increased use of violence prevention approaches. And there's also post-incident. So when there's an acknowledgement and really a non-blaming emotional support from peers and supervisors after that violent incident, there's an increased perception of psychological safety, and that can really help to diminish any secondary psychological injury, which we just talked about, that can result from the violence when there is not support or when there is blame. And the next two concepts are around team and debrief. And you can see where they're positioned there along that timeline. So when there is a team-based approach to education that's really supported by team-based discussions, then there is an increase in team cohesion. So there's a shared understanding, a shared sense of belonging. You feel like you're part of a family, or you know that somebody is going to have your back if you get into a situation. And that results in a consistent team approach to violence, enacting of policies and practices related to violence, as well as an increase in organizational learning when you have that team cohesion. And secondly, if there is consistent and timely debriefing of violence with individuals and teams, as well as a communication of action that includes care planning for violence prevention, that often can result in a decrease in cynicism and normalization of violence. So there's less of a tendency to accept, well, this is just part of my job and I just have to accept it and put up with it. And so when there's decreased cynicism, then there really is an increase in reporting of violence and aggression, as well as that organizational learning piece. And the last area of key finding is work culture. And as I mentioned, it really stretches along that entire continuum of the timeline. And so if there are clear and transparent policies and consequences for unacceptable patient and visitor behavior, then the staff are more likely to really feel empowered to set limits and to manage aggression and violence when they know that they're being backed up by those clear policies. And that results in an increased use of violence management approaches and skills. As well, when there's an organizational and unit culture where employees do not fear being judged or blamed for patient violence, then we have a decreased fear of failure and of being perceived as incompetent. So they might be more likely to try a new skill, maybe take a risk, not being completely confident. Maybe it hasn't been practiced enough, but they're still going to try because they know that they work in a unit and in an organization where they're not going to be blamed if something doesn't go well. And that can result in an increased use of skills or new approaches to manage the violence, as well as an increase in reporting of violence. And so I'm going to pass the microphone over to Sharon, who's going to talk a bit about educational effectiveness. So, where we wanted to go from the very beginning of our project was actually to have some recommendations. The entire intent of doing a realist evaluation, or review and evaluation, is that it is intended to be practical. And so what we've done is given a sampling of some of the recommendations that would come out of the findings that Michelle just went over, and that we're going to be building on in the realist review or realist evaluation that I will be talking about in a minute as well. So we broke it into the 4 quadrants of education, ongoing support, policies and practices in the workplace culture. Seemed like a reasonable framework to use. So one of the things is that if the occupational health training, which a lot of the violence prevention tends to fall as this thing that is separate from clinical training. So it's something that you'd go to the occupational health class to learn how to deal with violence. And in the same way that when Michelle was overviewing who teaches it and do they understand your work, one of the suggestions and in some of the literature as well is that if there's an integration of occupational health training with clinical training, then that is a model for the education assists people. And that's something that would be a very practical recommendation for organizations to look at. The training for leaders, there's a lot of information about training of the employees, the frontline employees, but there's very little in the literature at all, and to be honest, likely occurring, of actually training the leaders. And if you think about our recommendations, a lot of what influences whether people learn and use the skills have to do with the support they get, some of the policies and a range of things that actually rely on other people having training. And what's really interesting in, particularly with the training of leaders, is that non-judgmental approach and the acknowledgement and that feeling of support. And ironically, we sometimes think that we want leaders, they all have to be warm and fuzzy and do all of that all the time. And really what we are seeing in the literature is that if you have a warm and fuzzy manager who doesn't do this because either they just don't know, they're too busy, we've never trained them, it's actually more damaging because those people had expected support. And so you've got someone with whom, as a leader, you expect to have that warm and fuzzy support, and when it's not there, it's even more damaging than if you hadn't expected it, or in the beginning. And the part about the credible trainers. And so looking at who's giving the training and the kind of examples and things that they're using so that it's relevant to people.
Under ongoing support, the whole concept of access to expert advice, modeling of the violence prevention skills, in the range of clinical areas, this is a really common practice. There's champions, there's people who are expert at something that get embedded in a unit, so somebody will be given extra training so they can be a resource, and it isn't something that primarily has been done for violence prevention, and so that's an avenue for people to be looking at. The ongoing support, acknowledgement and support from the leaders and peers after violence. And that is something that organizations put structure around, training and structure so that they ensure that it happens. Under policies and practices, I think there's two pieces, consistent actions and response to incident reports. You have to have some policies and practices, but if they're not enacted, they're not a lot of support. And what seems to be the most important thing is what happens after violence. And are people feeling that they have response to the incidents, they feel something is going to happen from it. So if they're going to report it and they're going to be facing injury, they want to know that it's going to change and have some hope that they won't continue to face violence. And finally, the whole workplace culture about non-blaming. And this doesn't mean just related to violence. It actually can be related to clinical care. So that people have all sorts of emergency situations in healthcare, and if all of them, and the whole culture is such that we don't blame each other, we don't look for fault, when we're trying to learn from what we've had an incident, whether it's somebody in a cardiac arrest or trauma, what we're learning is that if in those situations as well, they don't feel that they're being blamed, and it's about learning, and it's about how can we do this together better next time, as opposed to, wow, you didn't do this, or you did it wrong. Across the whole culture, if that's there, then it bleeds over into the violence prevention as well. And the sad thing is that a lot of what you saw in terms of support, if people are feeling that they are unlikely that they may be blamed if something goes wrong, not only are they unlikely to even embark on some of the skills themselves and try to do what they've been asked to do from the teaching, they may be unlikely to go help their peers. So we've got a whole cycle of things that don't actually support the actions that we know that are going to help the most. So where do we go from there? So Michelle and I have completed the Realist review, and we've actually about 7 or 8 weeks into a Realist evaluation. We're very privileged to have WorkSafe BC funding, and we are working with 3 health authorities, and we are collecting data actively as we speak. And I'm going to tell you first where that fits with the Realist review, which is a little bit different than often what happens when you do a literature review for some other kinds of studies. Because this is the reason that we really wanted to do the review first, which sometimes sits as its own project and that's all you do, is that we take a similar process to the Realist review by collecting our own data, but we actually start with the theories that we came up with from the Realist review. And the intent, it's a very focused intent. So we are doing qualitative data analysis, collection and analysis, but it isn't a random tell me about your experience. It's actually refocused on getting those same explanations, finding the meaning and figuring out what some of those overarching theories are. So as you mentioned, as you remember when I talked about the beginning, there will be individual differences, but there are some patterns, and we're looking for those what we call semi-regular or demi-regularity patterns of how things work. And to be honest, we're already seeing it, and we're only 7 weeks in. So what we're doing is we're validating, refuting, and refining the theories we came up with from the review. Our evaluation data is actually being coded to those initial theories, and as we go, we refine them. So it's an iterative thing. We don't collect all the data and then go in a room and lock ourselves away for 6 months. Every time we've done some interviews, we're coming back and we're looking at it, and as we code, we refine what we're coding against to the part where you're getting closer and closer to those plausible explanations about what's going on. And then finally, so where our data collection is, we are in Fraser Health, Vancouver Coastal Health, and Island Health. And we are doing, in each of them, we are doing we're doing data collection in the emergency department at an urban tertiary center, a community center, and a rural hospital. Because recognizing those contexts that we talked about being so important may be very different across these kinds of hospitals. And they may be different across different organizations. So we really wanted to get quite a wide base. In a qualitative type of research, the numbers that we are gathering is a bit astounding. We're probably going to have up to about 200 people involved when you look at our interviews and focus groups. And it will be around 50 interviews and then some focus groups. So interviews with frontline emergency staff in each of the centers, and then focus groups. We wanted to hear from acute care leaders, and in really large centers, those tend to be leaders just within the emergency department because it is so large. And in small sites, everybody does everything, so it tends to be broader. Violence educators, so the people actually providing the course, and the joint occupational health and safety committees, because they're the people who do that oversight at the very end. So we're bringing that data from different perspectives together. So I just will say one thing before summary. The realist approach is a methodology. It doesn't have specific methods of its own. It shares methods with other kinds of research. And often people will do some quantitative analysis as well, given that we know that a lot of the metrics we could use for violence are not that reliable. We haven't gone there. It's our hope in the future that if our recommendations are implemented, that's a place that people could go once we have more confidence in reporting. And because what we're hearing even in our interviews is, I actually got punched and I didn't report it. I got scratched, I got bit. They may have actual injuries and we're not even seeing them reported. So we don't have a lot of confidence that what we'd be seeing if we started to look quantitative now would really help us. What we are thinking that our study is doing is demonstrating how a realist approach to a literature review can inform the question. And again, a realist approach is really appropriate when those are the kind of questions you want to ask. And that is the how, why, what, and who that you can then use to inform policies and programs. To highlight the importance of a non-blaming approach to violence that promotes psychological safety and organizational learning. And we think our study has offered practical opportunities to enhance and refine the violence prevention strategies even before we've even done the evaluation. There's things here that are practical, and we have had an opportunity to share some of these findings with clinical leaders, and they're already fairly excited about it. So it's great. And finally, it does provide the explanations that we're going to be using and we are using in our realist evaluation of the BC health authorities. For those who really are keen and eager, we have a list of realist methodology resources, and it's a very interesting community. There's a listserv group of now over 1,000 people across the world doing this kind of research, and at any given time, a PhD student such as myself may pose a question, and a prominent researcher on the other side of the world will answer within a couple of hours. It's probably one of the most phenomenal resources I've ever seen. In particular, the last on this list is a book that was just published this last summer, and by a lot of the people who are very experienced in the field. This was primarily out of the United Kingdom, and it's slowly starting to spread more across other parts of the world. We would like to acknowledge our funders, and WorkSafe BC, who is funding it. Public Scholar has supported, in particular, my education, which needed to come out of Great Britain, and the Partnership for Work Health and Safety, where our project is embedded. Also Manal, who helped with the original Realist search, Suhai Marino, and we had some clinical content experts who helped us develop our original theories that we used to start our Realist review. And thank you very much.
Thank you very much, Michelle and Sharon. This was very enlightening and it tied quite nicely with the previous report that we had. So we have time to take a few questions here, and we'll give time to our online audience to chime in.
Oh, there's just the one mic. Oh, is that right? Okay. Thank you very much. I have heard some of this work before. I, of course, know the work that you're doing, and I'm always learning a bit more about it. You know, I don't know why this struck me this time around, hearing this work. This is maybe a little bit outside of the scope of your work, but coming from the kind of occupational health and safety or hygiene paradigm, I guess I'm intrigued about, in this whole issue of violence in healthcare, whether anybody is looking at how to reduce the violence amongst patients. I get that your purview is the workers and what the workplace can do, and it just struck me as the kind of, you know, when we talk about upstream prevention factors, you know, which is not easy. I know that's complicated, but whether people are looking at what's causing the violence in patients and how to address that. Maybe that's outside of your scope and you can say that, but.
Well, it's certainly outside of the scope of my PhD, just to be very clear. No, the predominant research has been on the prevalence, and I get all of the alerts from every database in the world that tells you something new that's come out, and every single country and every single place is the prevalence, incidence, and the reasons for the violence in different places. So there has been a lot of research, and it is so multifactorial. And one of the reasons this makes sense to me, particularly as somebody who, my head in my world is as that healthcare administrator, and is that it isn't just one thing, and they intersect. And so some of the ownership for the violence occurring is us. It's how we approach people. It's how we keep them waiting. It's how they're treated. It's when their needs aren't met. So there's a piece that lies within how we do our job and how we set up our system, as an individual, as a unit, as an organization, as a society. There's things that sit outside in the whole society and violence. There's a whole range of factors, and I guess it does need a multi-pronged approach, and that's why I think the fact that the main thing that we've done is just educate people in the healthcare. So we're only looking at this one little piece, and I think that's, if we've already done that, we have to figure out what's working and not working, and I think until we actually get a handle on that, people probably aren't going to look at a larger of other things. Some of the things we are hearing is that we need to make this story more known, and we need people to understand they can't do this. As some of even people in our interviews have said, is you would not go into a Starbucks and treat them the way you treat somebody when you walk into a merge. And why is that? And why as a society are we allowing that? And so if somebody comes in, they don't usually fear any kind of consequence or retribution, because they just figure they're going to be cared for anyway. And so I think pretty well every emergency being the sort of the microcosm of every kind of patient that comes in the hospital, because they're going to see people in distress, trauma, mental illness, addictions, dementia, everything that often contributes. So I think we've understood where the violence comes from, how to stop it, maybe a different thing. And in emergency, every single nurse, every single day, and I don't say that lightly, experiences at the very least verbal violence. And most of us don't see that in our jobs. And for some reason it's just part of our job. It is complicated. So we need to ask the hows and whys, because just measuring it isn't going to help us know what to do with it. I don't know if I answered your question.
So we have a question from the online listeners, and this is asking you if don't you think that patients and their family members need education as well?
Yes. It's a really excellent point, because it is, as I think, it's a societal problem where we've come to accept it. And so I guess there's multiple layers of where that education needs to come from, whether it's governmental, whether it is media, whether it's a hospital setting the limits. So there does need to be an approach from that as well. But we also, as came up in some of our findings, where when we are inconsistent within a team and within a site, we're also giving a different message. So we need to address it in a variety of ways. So if we do have a policy, and a number of hospitals have looked at something called zero tolerance policies, and it causes a problem sometimes for clinical people, because there are people who, in their heads, they realize this is not intentional behavior. People who are not, they may have dementia, they don't know what they're doing. They may be, some people just coming out of an anesthetic. And it's a person, it could be any one of us in all honesty, and they come out and they are absolutely delirious. So clinical people have a trouble with that idea of zero, because we realize we are never getting to zero. Like, we're never getting to zero overtime, we're never getting to zero violence. But where do we start to be really clear about what we tolerate, what we don't, so that if somebody comes in and treats you a certain way, and you respond, that I'm going to do the same thing. So they get the same message. And I think overall, within and across, we've not been very good at that within healthcare. So yes, definitely education, and also consistent, and to come together to figure out what that looks like.
When you get to the stage of the evaluation, you mentioned that you're going to have 200 people, 50 interviews. Are you including clinical placement students in those conversations?
No. And part of the reason at this point is that we're looking at employees. So there's certain agreements and all the rest of the complication, which is what I understand. There has been some work done already with students. And what we're hoping for, and I guess what I like about this approach, and why it's really resonating with me as somebody who's looking for those practical solutions and came back to university to find them, is that when we can come up with those generalizing theories that says in these situations, and part of that is for whom, and a lot of what we talk about is, well, who would that be different for? If that's how you feel when that happens, and this is the outcome for you, would that be different for anybody else? And we do hear a lot about level of experience, and we talk about the new grad. We haven't generally talked about students, because the people we're speaking with have limited interaction, let's say, with each student. What people have been reflecting on also has been, if I'd had this as a student, and what that would be like. So I think we're capturing some of it in level of experience, and I think it would be a great place to look after. And this, again, we're dealing with emergency, so we think we're going to find things that are generalizable across, but we're not trying to say this would be in every situation everywhere. Neither are we saying this would work in Bangladesh or another place that may have very different contexts. But overall in British Columbia, acute care, we're probably going to be finding things that would apply. And I think the less experienced staff might be very similar to the new grad. Yeah. Right, and for those who couldn't hear that WorkSafe BC considers clinical placements to be employment, and so they would be under the jurisdiction of the school of nursing to which they belong. Yeah, so I think it's interesting things to be able to see, even here, transferring that to what is the support they receive from who they perceive as their leader, and acknowledgement after. And so some of it I think would be very transferable. We're not particularly focusing on students.
Thank you. I do have a question, because you were mentioning that this approach to looking at violence prevention comes from the UK. So how are we doing in the world of developed countries? How are we doing in terms of violence and violence prevention compared to other countries, say the UK, the US?
The methodology for Realist isn't related just to this topic. It's a methodology for evaluation. review and evaluation. And so I think we all have very similar issues. I haven't been able to find a realist study that is focused on the violence prevention. And I keep looking because I'm hoping to find kindred spirits in the world. So I think this is going to be part of the start of people maybe looking at it a different way. Had the opportunity in October to present at the International Conference on Violence in the Health Sector, and I couldn't even get off the stage. I had a little lineup of people who wanted to talk from various countries and different places because they got intrigued that maybe a solution, because people are very hungry for a solution and a way they can actually do something measurable. If we did a study where what we came back and said is the manager should keep in mind that staff need acknowledgement, is a very different kind of recommendation, is they need training. Managers need training on how to do this piece. And so I think what people are seeing is that this may have benefit. I think everybody's pretty well facing, and some people it's a lot more. In some countries, violence is part of their daily life outside of work as well. So it may be different.
So we have two additional questions from our comments or questions from our online audience. This one goes as follows. So this person works with interior health in the 2000s, and IH had started implementing education for families and patients and implementing consequences for these patients and families, including behavioral contracts or withdrawing services. She says it was not an easy nor popular approach with workers or the public. So do you have any comments or thoughts on that?
I'd love to see an evaluation of it. So interior isn't one of the places we're going. We're working with the occupational health directors for all of the health authorities, and among them they decided on 3 because we realized that was the amount that we could do, and it's a bit of a stretch at that. And what we are discovering is that there are lovely, wonderful things like this that people are trying. Because people are very inventive out of necessity. And so we're learning about them in the health authorities that we're in. Really excited to hear about some in the health authorities we're not. And I think it's going to be continually part of the story. So it's going to be really interesting for how interior health is able to evaluate how it's working, and they may choose to use an approach like the realist approach in that evaluation.
I'm going to keep the mic since we have another question here. So this question asks, when your work is complete, what type of knowledge translation will be provided to the BC health authorities? Any type of guidelines or strategies for education? So what is it that's coming up?
That's the $10 million question. We have not defined yet what the knowledge translation strategy would be, but it is one of our biggest priorities at the end, because this is not going to be a report that sits on a shelf or a dissertation that's going to just be something that gathers dust. So we are going to be working with the health authorities to determine what that needs to look like. At the very least, there's recommendations in a report and presentations and all the kind of regular things. We're hoping to get a lot more creative than that. And I think I scare my main professors a little bit sometimes when I start to think of movies and videos and plays and, maybe the musical. So we are going to need to look at things differently. We're really lucky in that we do have people's attention. WorkSafe funded this, just funded it. They just really were very, very supportive, so they're very keen. And we're seeing everywhere we go people of interest, and that's the start. We're not having trouble getting people volunteering. We're not having any of those things. So with that interest is going to also come some input into what this could look like to be really practical. Definitely back to the occupational health directors, back to WorkSafe. We're hoping to get some Ministry of Health attention, and then we're hoping to do something really quite creative with it.
So I had another question here that I missed. Apologies for our person asking. So someone was interested to know if police was involved in violence interactions, and how would you see them as an agent in this whole knowledge translation or possible interventions?
The role of security or police seems to differ depending on the size, location, and a whole range, kind of violence, those kinds of things. And I think what's become really clear is and I'm speaking from sort of informally on what we're seeing in our interviews and focus groups so far, is that that integration and teamwork is really critical across. And there is a lot of interaction with the justice system and the hospital system. And those partnerships and that understanding and clear working together is really critical. They're not actually part of this particular data collection in terms of talking with them, but it's certainly been woven into everything that we're hearing. So I think it will be coming out in the strategies. That, again, some of the strategies would then embark on how do you foster those relationships and those kinds of things. Not sure if that quite answers it.
So there is a lot of questions from our remote audience, a lot of people who wanted to share their experiences, some people who are past healthcare workers. I'd like to let them know that they can reach you. I'm volunteering you. Is that okay? Yeah, by email. And please join me in thanking both Michelle and Sharon for the presentation today. Thank you.